Greetings from Jagsonpal Pharmaceuticals Limited. I, Dr. Vipin Tyagi, welcome you to the webinar today on endometriosis and fertility. This webinar is brought to us as knowledge sharing initiative by Jagsonpal Medical Services. The webinar is organized by Association of Maharashtra Obstetrician and Gynaecological Societies, AMOGS, and Maharashtra Chapter of Indian Society for Assisted Reproduction MSR. We feel privileged to welcome our entire distinguished faculty, Dr. Nandita Palshetkar, President AMOGS, Dr. Sunita Tendulwadkar, MSR Chairperson. We would thank you AMOGS and MSR Society for this webinar. We do miss Dr. Arun Nayak, Honorable Secretary AMOGS, and Dr. Amit Patki, MSR General Secretary here today. We thank you ICOG for accreditation of 1 point. We are missing Dr. Mandakini Meg and Dr. Parag Biniwal. We welcome Dr. Rohan Palshetkar, Joint Secretary AMOGS and Managing Committee Member of Mumbai Obstetricians Gynae Society. Convener of this webinar, he will be introducing today's moderator for case-based panel discussion, Dr. Kuldeep Jain from Delhi. We have stalwarts from Maharashtra as panelists today, Dr. Amol Lunkad, founder member, Gynae Endocrine Society of India from Pune, Dr. Ashish Kale, executive member, Maharashtra ISAR from Pune, Dr. Chaitanya Sembakar, chairperson, AMOGS Infertility Committee from Omega Hospital, Nagpur, Dr. Kalyan Barmade, chairperson, Public Awareness Committee, FOXY from Latur, Dr. Kundan Ingel, chairperson, Infertility Committee, FOXY 2022-2023 from Pune, and Dr. Sachin Dalal, IVF specialist from Mumbai. We welcome all attendees present with us today. I hope all of you will enjoy this session. It may kindly be noted that this session is streaming on Facebook Live and recording will remain on Jagsonpal's YouTube channel for reference and knowledge sharing. I will now request Dr. Rohan Palshetkar to kindly initiate the session. Sir.
Thank you so much, Dr. Vipin. So everyone, welcome to this webinar on endometriosis and infertility. Before I start, I'd like to invite our MSR chairperson, Dr. Sunita Tendulwadkar, who's taken her time out. She actually has an emergency LSCS right now. So she's taken her time out to be with us to address the entire gathering. Dr. Sunita Tendulwadkar is obviously the MSR chairperson, but she's also a very dynamic IAG president as well. She's the director of the Solo Clinic, Center of Excellence Infertility and Endoscopy, and she's the founder and medical advisor of Solo Stem Cell Clinic as well. There's so many achievements she has, it's impossible to cover them. Sunita Auntie, I'm going to hand it over to you to just address the gathering really quickly.
Rohan, thank you so much for this opportunity. I was going to tell you, stop that. It's an academic session and I congratulate you. At the end of a day, even with the beginning, you have 100 participants already. That shows the talent, that shows the interest among all our group, how much they are interested in learning. I want to say only one thing about you, Rohan. You are the most enthusiastic, my MSR member. The amount of social programs and academic programs you are doing non-stop for this organization is amazing. And I thank you. And I look at you one day to be a chairperson of MSR. I don't want to take much time and I just thank you for having MSR with this intelligent group. The moderator Kuldeep Jain, I wish you all the best. And I'm sure you have such a wonderful panelist that every one of us are going to have a great academic feast today.
Thank you so much, Sunita Auntie. Thank you for coming really quickly because I know you have to run for an emergency LSCS. So thank you so much for being with us. I'd like to introduce now Dr. Nandita Palshetkar. She's the current president of AMOGS. She's a past president of FOXY. She's been the director at 9 Bloom IVF Centers. She's a professor at OBGY. And as you can see on the slides, there's a lot to cover with her CV. So Mom, I'm going to hand it over to you.
Okay. Thanks, Rohan. First of all, I think I would like to congratulate everybody. It's great. I think, Kuldeep, thank you for doing this for us, for AMOGS and MSR to come together and do this program. And, you know, endometriosis is something that I am really keen about. I am interested in, and I love the subject because I think we can do so much and there are always such new things coming up. So I'm really, really happy. And, you know, I've known Kuldeep for, I think, 30 years, and we worked together on different forums. And I've always respected his surgical skills, his depth of knowledge, his academics, and moreover, he's a fantastic friend. So I'm really happy that he's here today and working with AMOGS and MSR. And MSR, what can I say? Sunita is... I mean, we are like twins, actually. We are spiritually joined, I should say. You know, both of us are very, very spiritually oriented, and I think that's a strong bond which will always remain forever. So I'm really happy. And all this young brigade which is there, I think whoever I can see on the screen, Chaitanya is there, Kundan is there, Ashish, Amol, Kuldeep is, you're not in the young brigade, okay, Kuldeep, Kalyan, Sachin. I think fantastic guys, and all males, huh? Not allowed. Where are the women? But I think we women will take a back seat so that y'all are all allowed to talk. But really, all you guys, I think you make AMOGS proud, you make MSR proud. And Kuldeep, trust me, MSR, all these guys are so well read, because when we had the conference in Goa, and I think, you know, even Sunita had the conference in Goa, these guys came up with such fantastic stuff, and they're absolutely updated with knowledge. So I think all the participants, y'all are going to get some real pearls of wisdom, get the latest facts, and I think in endometriosis, there's always a lot of new things to learn. And Kuldeep, all the best for your elections also. And I think I will just end my talk here and let you get on with the program. And Rohan, definitely, I think you've been doing a great job. You've been working very hard. I can see that. And all the best in your future endeavors. Thank you.
Thank you so much, ma'am. Now, without taking too much time, I'm going to invite our moderator, Dr. Kuldeep Jain, to start the panel. He's a chairperson of the Endometriosis Committee 2017 to 2019. He's the founder, secretary, and immediate past president of the Indian Fertility Society. He's the member and board of directors of the International Federation of Fertility Societies, chairperson of the International Exchange Indian Fertility Society, the organizing secretary of IFFS 2016. He's the editor-in-chief Fertility Science and Research, which is the official journal of IFS. He's trained in IVF and endoscopy from KJIVF Singapore, examiner of Delhi, Jaipur, and Srinagar universities. Sir has many publications. He's a scientific committee member of IFFS, the member of the International Scientific Exchange Committee of FOXI 2014 to 2016, executive member of the Association of Obstetricians and Gynaecologists of Delhi 2016 to 2018, ex-president of the East Delhi Gynaecologists Forum, the member guideline of the committee of ISAR 2008. He's an author of many books. He's received the Appreciation Excellence Award from IMA Rajdhani Gaurav Samman, written plenty of chapters, and the list just goes on and on. Sir, now I shall hand it over to you to please take over the panel. Thank you so much, sir.
Thank you, Rohan, for kind words. And I am really happy to be connecting with all members of AMOGS and MSR. And for that, I will just like to thank Dr. Nandita, President of AMOGS, and Dr. Sunita. Both of them, they have been actually very kind enough to getting me connected to all members of AMOGS and MSR. We have been working together, Dr. Nandita and Dr. Sunita, and I must actually congratulate Rohan also, because he is the person I really admire since when he was actually entering into the field, because I have been seeing him growing like anything. So Rohan, really it is wonderful to be working with you and getting connected from with all members through you. So it is really great to be here on this panel. As Dr. Sunita has already said about Rohan, he is really a budding star. So I really congratulate you on all your achievements. Thank you, Nandita and Sunita. Thank you for all support. As you all know that the Foxy elections are coming in September, and I take this opportunity to take your support and blessings from AMOGS members as well as from MSR members. I have been working with Foxy for last 35 years in various capacities. I was my last assignment actually was chairperson endometriosis committee Foxy, which ended in 2019. And during this time, actually I met so many people throughout country, and I thought I should be playing a bigger role in Foxy. So now I am here seeking your support for Vice President Foxy North Zone this time. Please cast your vote in my favor on 1st September. It will be from 1st September to 10th September. Coming on to the panel of today, we are having a wonderful panel, a galaxy of experts, and they are all young, dynamic leaders in their field. And I am seeing the panel here. It is coming from all over Maharashtra, and they have already actually introduced Dr. So I welcome Dr. Amol. He is from Pune. Dr. Ashish Kale, again from Pune. Dr. Chaitanya from Nagpur. Dr. Kalyan from Latur. He is doing really wonderful job. I have been following him for last 2 months, and he is having really wonderful programs. So welcome Dr. Kalyan, Dr. Kundan from PCMC, and Dr. Sachin. So I welcome you all, and I think they are going to solve so many queries which everyone is having as far as the endometriosis and fertility goes. Ours will be a case-based discussion. So it will be really interesting, and I request all delegates also to put their queries in the chat box, so we will be able to take and solve them, answer them through our panelists. As you all know that endometriosis is a disease of controversy and complexity. It is chronic and multifactorial, progressive and recurrent, not malignant but behaves like one, and difficult to diagnose and treat. So it is actually starts whenever you are seeing a patient. It starts dilemma, with dilemma only, clinical dilemma. There are more queries rather than solutions. So my first question comes to Dr. Kundan. I will be asking question to a particular panelist, but all can answer. And if you are having something to say, just raise your finger. I will be able to entertain you. So this is Mrs. Lee, 28-year-old female, married for last 4 years. She has undergone IUI treatment 4 times. Last IUI was 3 months back. She presented with pain during luteal phase of her menstrual cycle, and her ultrasound shows single cyst of 4 centimeter with a few internal echoes in left ovary. What could be the probable diagnosis, and how will you go ahead with the diagnosis? Kundan?
I will like to put up differential diagnosis rather than a one single diagnosis.
Yes.
So either it can be a endometriotic cyst, or it can be a hemorrhagic cyst, or sometimes in a little rare scenario, we can see this picture as a dermoid cyst also. So it looks like a ovarian cyst, and these are the three probables. And to coming to diagnosis, the best way to
So
diagnose
how you are going to confirm whether it is a endometriosis or hemorrhagic cyst or dermoid, as you told?
transvaginal sonography is the best way and the best modality to diagnose this. The picture which we see on the transvaginal scan will help you to differentiate this and come to a final conclusion.
Okay, anybody? Yeah, Dr. Amol, you like to add something?
We will also like to see her history, whether she is having any history of dysmenorrhea or dyspareunia, and her examination, her per speculum per vaginal findings on per vaginal examination, whether there is any nodularity in her pouch of Douglas or the uterus, how are the uterosacrals felt, any adnexal cyst which is felt. And of course, a transvaginal sonography will be very much helpful to differentiate.
Chaitanya, you want to add something?
Yeah, Kuldeep sir, I think the ground glass appearance is the classical feature of chocolate cyst. So if you get that, then it confirms the diagnosis of chocolate cyst.
Okay, but many a times they are the similarity in the appearance. So anybody will like to add any other thing here? Any role of color Doppler in differentiating between the endometriosis and hemorrhagic cyst? Yeah.
Kuldeep sir, Sachin here.
Yes, Sachin. Yes.
Can I talk?
Yeah, please.
Okay, sir, what I would like to just add here is to do a sonography immediately post-menses and not pre-menses. Because a picture of a cyst pre-menses, you will find so many times that post-menses, a hemorrhagic cyst or a corpus luteal cyst has just disappeared. So just one sonography in the luteal phase, I would not make any decisions. I would probably call her back post-menses and do a sonography. And as Kundan rightly described the differential diagnosis, that is what mine diagnosis also would be.
Yeah, so I think that is a very good and relevant comment as far as the follow-up of these patients concerned. So first thing is you have to keep a lot of differential diagnosis in mind. Because she has come at that time when the follicle has ruptured and it could be just a simple cyst. But of course, when you are having a typical ground glass appearance like this, there is no doubt usually. And in these patients, actually, it is always better to go backward because she is being followed and taking the treatment. So if there is a persistent cyst, in the previous record, then that might really help. But if it is first time, if you are seeing this cyst during the luteal phase, then certainly you have to exclude corpus luteal cyst or hemorrhagic cyst. So I think it is very important from clinician point of view that you should always go backward to see the previous ultrasound, and that might really help in making the diagnosis, and again follow up at post-menstrual phase. So post-menstrual phase, if you follow these cysts, then you will be wiser to make the diagnosis of what you call endometrioma. Anything else you will like to add? Is there any role of MRI here or CA125 in the diagnosis of endometrioma? Anybody wants to comment?
Can I say something?
Yes, Ashish.
Yeah, sir. First of all, there is a particular history that she has a pain in abdomen in luteal phase.
Yes.
So if you go through the history very carefully, usually this will point out towards the more likely the hemorrhagic cyst. As rightly said, the hemorrhagic cyst doesn't appear after the post-menstrual phase. So if you do the scan in the post-menstrual phase, you will not see the cyst. Then it is probably a hemorrhagic cyst. Secondly, you will have if the good UHG findings are there, you have the blood and you have a free fluid, or maybe there is a echo texture which is different as compared to the endometrioma. So there is another way you can find out whether it is a hemorrhagic cyst or whether it is endometriosis. Secondly, the adhesions. If it is too much of bigger cyst or 4 centimeter, what is narrated here. So usually you will not have a restricted mobility of the cyst.
Anybody will
I
like
like
to
to
confirm?
add here
Yes,
that
yes.
there is a very limited role of MRI in this patient. Otherwise, if you are suspecting deep endometriosis or bladder endometriosis, then MRI is diagnostic. Otherwise, I will not go for MRI. As you were asking about the CA125, it is more of a prognostic value post-operatively and doing it prior, and reports which are more than 35 are slightly diagnostic of endometriosis, but they are going to help you post-operatively as a prognostic factor and not for diagnostic factor.
I would like to add one point here.
Yeah,
As far
Sachin.
as CA125 is concerned, as Kullan has rightly said, there is almost all the guidelines, they say that there is no role of CA125, but FOXY guidelines, they say it has got a value in the treatment follow-up and not in the diagnosis, but in the follow-up. And one case study says that there was a very high level of CA125 of 6,114 units in a case of ruptured endometrioma. So this is something which I would like to add to this point, that very high CA125 may be seen not only in malignancies, but in ruptured endometriomas as well.
Yeah, so I think my panel, all panelists, they do agree that MRI routinely should, because that is what actually I wanted to get from all of you. What are the scenario where you will be having a MRI in endometriosis? That is number one. Second thing, the role of CA125 in diagnosis. So I think it is very clear that as far as the diagnosis is concerned, CA125 doesn't have any role. That message should go to everyone. Unnecessarily, people are getting CA125 for the endometriosis patient, because it doesn't help actually in deciding the treatment as well as in the management.
And
Only thing they are, yeah. Chaitanya, you want to add something?
Yes, sir. And one more point is endometriosis may be present even with normal CA125 levels.
Yes, yes.
That
So,
is the message.
Basically the message which I will like to go to the audience through all of you, that CA125 is not the, because at present we are not having a definitive marker. It will be very, very good if we have a biochemical marker, but at present there is no mark, and CA125 should not be used for the diagnosis. Yes.
In ultrasound, I would like to add one thing is the transrectal ultrasound. So many centers are doing this ultrasound very successfully in a patient with rectal endometriosis and DIE, deep infiltrating endometriosis, and they are getting good results.
And I think, yeah, that is again a thing which I will like to, because it is a underused modality. Transrectal ultrasound is a underused modality. This should be used more and more, and until unless we realize that it is having a very high sensitivity as far as the deep rectal endometriosis and DIE is concerned, because it is having a very high sensitivity. Even in some studies, it is better than MRI to pick up deep infiltrating endometriosis. So I think that thing should also go to the audience, that we should be using more and more transrectal ultrasound rather than going for MRI. Yeah, Chaitanya, you want to add something?
There is one social angle to this CA125, sir.
Yeah.
Whenever the patient comes to you with a chocolate cyst or a cyst,
yes, yes.
and you advise CA125, CA, people think that means cancer,
yes,
and then they get anxious.
Especially
so as
young adult, where the patient is coming with pain and she is unmarried, and so I think that is very valid point again in counseling, because once you write CA125 and it goes to surgeon, many times the after ultrasound the patient goes to surgeon and they will chop up the ovary. So again, that is a very, very important and relevant point in this discussion, that CA125 should be restricted, MRI should be restricted. We should use more and more of transrectal ultrasound to basically finalize whether patient is having, apart from endometrioma, there is a deep infiltrating nodule, especially in those patients who are having difficulty in defecation. Yes, Sachin, you will like to add something? Otherwise,
yes, sir. I would like to add a different angle to CA125.
Yeah.
The CA-125 report, when it comes, it clearly mentions in the narration below that levels more than 35 are also seen in endometriosis. So what I normally tell the patient is this is just a surrogate marker for endometriosis, and it helps me in diagnosing and convincing the patient that she is probably having endometriosis. And the patient is categorically told that this is not done for malignancy, but it is primarily done for endometriosis and probably a surrogate marker. Secondly, I would come to a very important part in history that probably we've missed out. One is dyspareunia, second is dysmenorrhea, and third, very importantly, is dyschezia, especially during periods if a patient complains that she's having painful motions or she's having blooding during motions during the periods. That can be classically diagnosed as a DIE and probably stage 3 or stage 4 endometriosis.
So I think that is another point which has come out of discussion, that suspicion is very, very important, especially in young patients, because endometriosis usually starts very early, but it takes a lot of time to reach to a diagnosis. Average age is around 7 to 8 years before it is diagnosed. So I think high index of suspicion, a better and thorough history, and of course the examination and these ultrasound. Ultrasound is the backbone for the diagnosis, that can be substituted with color Doppler, and whenever there is a doubt, certainly MRI can come into the picture. So this is my next question, and this is coming to you, Ashish. A 34-year-old lady married since 4 years has 6 centimeter endometrioma with infertility. How will you manage? There are 4 options: medical management, IUI, laparoscopy, or IVF.
Sir, in this case, I really wanted to know much more information regarding the 4 years of infertility. She is having a 6 centimeter of endometrioma. What is her AMH now? That I wanted to know.
Okay,
then I wanted to know about
AMH is one thing. AMH is one thing which you will like to know. How it is going to help you in management? Can you
Yes.
tell me, Dr. Ashish?
Sir, basically, if the with the 6 centimeter of endometrioma at 34 years of age, and if the AMH is low, I will not go into the operative modality or IUI for that matter. It will be very effective for us to go for IVF rather than waiting for more years to make her for conception. So it is always better to know the AMH at an earlier stage, and secondly, what is the semen parameters also, because only this is the endometrioma of 6 centimeters, and thinking that if the semen parameters is very bad, so only to make much more attention to the endometrioma. As a case of infertility, we have to look forward for these two scenarios.
Okay, so AMH is 2.8, semen parameters are normal.
Then it is better that if she is symptomatic or not. If 6 centimeter endometrioma and she is symptomatic, then it is better to go for any operative intervention. If she is not
infertility, she is infertility. She has come to you for infertility.
Yeah, but with the infertility, whether there is a pain factor to it, if it is a 6 centimeter without any pain, so I will better to go with the IUI in that matter. Stimulation
without any intervention. Without any intervention.
That's why I asked whether she is a symptomatic or whether she is not symptomatic.
She is not having that the pain too much. She has come to you for infertility. 4 years of married life. Will you go for IUI directly, or you will like to have some intervention and then advise
about her tubal status?
Sir, I like to add here that any patient who is 4-year infertile, already 34 years of age, I like to do hysterolaparoscopy for her with removal of this endometrioma with as much as possible. Yes, sir.
Yeah, I can't see you here. Okay, yeah, go on, please.
So anytime such patient with 4-year infertility with 6 centimeter endometrioma, I like to do hysteroscopy, chrome perturbation test with removal of this endometrioma. Prior doing the AMH level, that will be helpful for me to know what is the status of her ovarian reserve. And I like to remove this with aqua dissection with minimal damage to the follicles of the ovary.
Very good, Dr. Kalyan. I also agree with you. She is having 4 years of infertility. Whenever you see a endometrioma, it is again put directly into grade 3 endometriosis. Okay. So if the AMH is the deciding factor, AFC is the deciding factor, then certainly that has to be taken into account. And even if the AMH is good, it is required to counsel the patient before you put a scope inside. So I think these are the concern. Any other concern when you are deciding for laparoscopy here?
Sir, another concern about the laparoscopy, when you are doing the laparoscopy with such a huge endometrioma, there is always adhesions. So the tubo-ovarian angle is going to get hampered. So it is better that one should be taken into account of the laparoscopy prior.
Yeah, so you have come out with the answer that IUI may not be helpful directly here because she is already having such a huge endometrioma, and 99% time you will be having tubo-ovarian relationship on both sides altered. So IUI is no. Anyone for medical? Anyone for medical management here?
No, I don't think so. There is
no role of medical management.
Okay, okay. So all my panelists, they are of view that there is no medical management in this case, no IUI in this management in the management. So two things are out. Now we are discussing whether to go for laparoscopy or for IVF. If it is 2.8 AMH, normal semen parameter, certainly laparoscopy is the answer to this patient. Of course, if you are having a endometrioma, there are seminal parameters which are actually not in favor, and AMH and AFC is very low. So I think these
another factor, sir, I'll decide on if the size was less than 4 centimeter, I would have thought of doing something than doing a laparoscopic surgery. The main aim of doing a laparoscopic surgery.
If you are having a 4 centimeter endometrioma, now come down to 3 centimeter endometrioma.
Yes, now it is 3 centimeters.
This patient is trying for 4 years. This patient is trying for 4 years. She has received all induction. Of course, IUI is not done. So you will prefer IUI or laparoscopy. 34 years, 4 years of infertility, 3 centimeter endometrioma, and coming to you for infertility treatment.
Sir, if I am very sure about my HHG finding and it is done it properly by myself, then I like to put her for 3 cycles of IUI in this patient because she is having an endometrioma which is less than 4 centimeter size. My main aim of putting a laparoscope is 3 reasons: to reduce the pain, to increase the chances of pregnancy, and to prevent the recurrence of endometrioma.
Any disagreement from other panelists?
Sir,
yes.
Sir, just one point. This is a very crucial step, and whenever you are doing surgery, the first surgery should be the last surgery. And if you are not a good surgeon, then there is a possibility of recurrence, as Kundan has already said. So you must think of the recurrence, which is very common. And second thing is counseling regarding possibility of diminished ovarian reserve because of the surgery. In spite of taking all the precautions by avoiding cautery and by doing stripping, you may land up with low ovarian reserve, and that possibility is always there. So you have to tell the patient, and that is the reason why we always prefer to do laparoscopy if there is a definite pain associated with endometrioma. And second thing is, you may actually think of tubo-ovarian relationship. Like if you are doing IVF and if you wish to do the ovum pickup and you think that this is going to help you. But as far as possible, you should avoid laparoscopy unless there is a definite pain which is a cause of concern to the patient.
Sachin, you want to add something?
Yes, sir. I would not agree with what the popular misconception is. The AMH, yes, it is important, but we have to look at the patient on the whole. We have had so many cases where the patients had stage 3, stage 4 endometriosis, where we've done laparoscopic surgeries. Yes, overzealous use of cautery should definitely be avoided. So what we do at the time of
I will come
right,
on
sir.
to that.
Sir, no, just get my point.
Before we take a decision, then only we will be discussing how it is to be done.
Agreed.
First, we have to decide whether this patient should go for IUI 3 cycles or laparoscopy followed by IUI.
Sir,
I think
straight away laparoscopy. We get the endometriosis under control.
How many people are in our panel are for laparoscopy first and then decide whether it is for IUI or IVF? And how many people for IUI and then laparoscopy or IVF?
6 centimeter laparoscopy.
6 centimeter always laparoscopy.
3 centimeter, 4 years, 34 years.
3 centimeter IUI.
IUI. Okay.
One more thing, Dr. Kuldeep, I wanted to add is along with AMH, AFC will be also very important, because many times in endometriosis, AMH is not reliable. And so AFC should be taken into account before planning our further treatment.
Okay, so my panelists, they say that IUI, if 3 centimeter, 3.5 centimeter, 34-year lady, 4 years. Now, I will like to just say why not IUI and why this patient should go for laparoscopy. Endometriosis is a disease of progression. If you don't do laparoscopy in this patient will be progressing to grade. If she is in grade 2, she will go in grade 3. If she is not, if she is in grade 3, then she may go in grade 4. That is number one. As I have, there are many papers, and it has been seen that whenever there is endometrioma, invariably in 80% of the patients, tubo-ovarian relationship are gone. There are enough number of papers which have shown that if you go for an IUI with endometrioma, the fecundity rate is 5% to 7%. Now, in this time of infertility practice, I think we need to optimize our treatment. And whenever we are talking of optimization, see, 3 cycles of IUI you have already done. Then you are going for laparoscopy. You are not leaving a chance for the simpler procedure. Then better you go for IUI and then directly go for IVF. That will be a better option. So laparoscopy is out. But in this patient, because the AMH is 2.8, you can optimize the result by your laparoscopy. And if you do IUI, you may get a fecundity of around 14-15%. While if you don't do laparoscopy and go for IUI first, then fecundity is always very low. So I disagree with my panel here that she is 34 years. She is at the borderline of her declining fertility. She doesn't have time. 4 years is already passed. If the tubes were working, then even you don't require IUI, this patient should have been, should have actually conceived. So if the patient has not conceived for 4 years, I don't think your IUI is going to work here. You have to go for laparoscopy, correct the tubo-ovarian relationship, and if you have done a very good surgery, can go for IUI for 3 cycles. Otherwise, move on to IVF. So I think that should be the right choice here. I disagree with all panelists. I go ahead. You have decided to go for surgery. Any role of preoperative medical treatment?
No role.
No role.
Okay, so again,
preoperative medications, it will cause hampering of the vision. It is like a tip of the iceberg what you are seeing. So majority of the disease is a retroperitoneal. If you are giving some medical line of a treatment, it will again regress and you will not have the completion of the treatment.
So I think that is a very good thing that all panelists are agreeing actually on on everything. So that is a very good sign. But I think disagreement is required at many places in the coming few slides. So there is no role of preoperative medical treatment, and I also agree here. Now, if you have decided surgery, Concerns we have already discussed. Concern is ovarian reserve, because there are enough studies. Whatever you do, whatever good surgery you are doing, there is 30-40% increase in the what you call the loss of ovarian reserve when you are doing endometrioma surgery. When you are doing simple cystectomy, it is 30% less. Again, there is a very beautiful paper. So whatever you do, whatever you say, however you are good surgeon, you have not used the cautery, but you are going to compromise the reserve. So that is a very big concern for all infertility consultants. So whenever you are putting a scope, you have to think 100 times whether this surgery is going to help this patient or not. Second concern is recurrence. That should always be in mind whenever you're deciding surgery. So try to reduce the recurrence. And one of my panelists has already said that first surgery is the best surgery, and that should be kept in mind in endometriosis especially. So you have entered, you have decided that you are going to do cystectomy here. What will you prefer? You will open, irrigate and leave, fulgurate or leave, or you will do the cystectomy? Anyone can take, anyone can start. This is a very good question for all audience, and they will really like to hear your views.
It is always advisable to do excision with stripping of the capsule, minimal use of cautery while you are doing this dissection. It's always better to do aqua dissection with some.
Sachin, you are muted.
Oh, I'm.
Yes, sorry, sir. Yeah. I
Yeah.
think Kalyan was telling, so I just muted myself.
Okay. Yeah, Kalyan. Yeah.
So it is always better to do excision with stripping of the capsule. Is always minimize use of the bipolar or any of the cautery. Do aqua dissection with normal saline plus vasopressin, and you can beautifully excise this chocolate cyst and try to avoid trauma to the ovarian surface.
Great. Anyone else will like to add something? Kalyan has given very beautifully.
Sir, can I add?
Yes.
Yeah, sir, before surgery, what I normally do is I sit with the patients and give them the option of either the cyst removal or to just do the drainage and give a good wash and come out. What I have seen over a period of time is if we don't do a cyst removal, the chances of recurrence are very high, almost 70 to 80%. That again, along with just a drainage also, there is definitely some fall in the AMH that is noted in the patients. When we do a cyst removal, the fall in AMH is more profound, but the chances of recurrence are much lesser. And the fall in AMH is there for a couple of months. At the end of 4 to 6 months, the AMH normally comes back to what the normal level was. So that is one thing that I discuss with all the patients pre-operatively, and then the intra-op plan of action goes accordingly.
Sachin, then what is the use of discussing them that you are going to do?
What do you prefer? That is what I was asking.
Kalyan, see, the reason why you discuss...
I think everybody should comment here. I will like comment of everyone from all my panelists.
Sachin.
What you will be doing, whether you agree with Dr. Sachin or
I don't agree with Sachin.
Sachin, what do you prefer? Because see, you have to counsel the patients for their betterment also. So what do you prefer?
My personal preference is always the removal of the cyst wall.
Right.
But if there is a patient who is a Google patient,
I think you have to, Sachin, Dr. Sachin, yes, I think I will keep this discussion very short. If the patient is coming with Google, I think you have to, this is our duty to make him leave Google and listen to you. So I think because in Delhi, almost 100%, 102% patients, they are coming with Google knowledge. Okay.
Absolutely.
So my half an hour goes to tell them that please leave Google aside and try to understand what is good for you. Okay.
Sir, easier said than done. Hota nahi hai.
I think no, you have to convince. I think that is our duty, and until unless we are not able to convince what is good for the patient and what should be done, they can decide whatever they want. But we should give option. it is having a very good outcome.
No, Sachin, because I am saying if he says that I want a incision and drainage only, then what you are going to do? That is what sir is saying, that
No,
we have to tell
Kalyan,
them what is the best.
Kalyan, incision of drainage में problem क्या होता है? In majority of the patients, we find that the endometrioma recurs very badly, and then the patient is on our head कि आपने surgery क्या किया कि 3 से 6 महीने में recurrence है.
Yeah, I think
sir, I wish
so
to
that is the
here.
yeah, Ashish.
Sir, yeah. The thing is that whichever patient is maybe Google and all that thing. What is need to understand is what we are going to do. If it is a recurrence, the recurrence after the drainage is high. It is given in Google also in everywhere. So if you are thinking of the complete surgery, is the excision of the cyst rather than the drainage.
आशीष हम लोग क्या सोचते हैं उसका मतलब नहीं है what the patient desires.
No.
You just operated.
1 minute.
I think
1 minute. 1 minute. The question here is what you are going to offer. What patient thinks that's not the thing. So
It is the cafeteria approach.
Then it is our advice has to be given. I think the excision, the stripping of capsule is the first line of treatment. Yes, you must tell the patient that the reserve is going to affect it. But I don't think so that incision, drainage and irrigation options should be discussed in this scenario. Because our first surgery will be the best
more
surgery.
point. Kundan,
That is
one
what
more
we
point.
follow.
Sachin, if you are doing, anyways, you are doing drainage,
Stripping.
then you can do it by ultrasound guidance also.
No, absolutely not. Because with
some people do
ultrasound
it.
guidance, the
It is
chances.
known to cause
Chaitanya, with ultrasound guidance, the chances of ovarian abscess is very bad.
Some people do it.
No, absolutely not advised.
I am also totally against that. But what I am telling you is,
Sonographically guided aspiration has much more dangerous side effects as far as the sonography.
I think we will finish up the discussion saying that Sachin is only concerned about the patient's request, and he has already told them that there are certain advantages and certain disadvantages. We'll move on to the next point.
Absolutely.
So, but I will like to conclude this point.
Excision is stripping of the capsule.
If you remember, my first question was, what are your concerns when you are putting a scope? If you remember these three things, that your concern is preserving the ovarian reserve as far as possible. Second, avoiding recurrence. And third is avoiding complication. So if you keep these three things in mind, before endometriosis surgery, I think your all decision will be good. Whatever decision you are taking.
I would like to add, sir, pain relief also.
If the patient is, so if you do a good surgery, if you do complete surgery, patient is going to be benefited even in our symptoms of pain. So I think it is a very clear-cut message. Incision and drainage is out of the endometriosis treatment. I think I am making myself very, very clear. Now there are two things: fulguration and cystectomy. They are both gives same outcome as far as the fertility is concerned. So whether you fulgurate endometriosis tissue or you do cystectomy, as far as the fertility is concerned, it gives the same outcome, but recurrence rate are very high in fulguration. When you are doing fulguration, so there are more evidence in favor of cystectomy than the fulguration. You can have a combined approach in those cases where you are finding that you are removing a lot of tissue. You can do the partial cystectomy, and where you are finding it difficult to remove, you can fulgurate. So combination approach is also justified in selected cases. Otherwise, try to do the cystectomy in right way, as Kalyan has said. Give the vasopressin, identify the plane, do the stripping in right plane, and minimize the hemorrhage and removal of ovarian tissue. So I think I have made myself very clear how you should do the surgery. So we are moving from here to the next case. Anyone for post-operative, what you call medical management?
Absolutely not. No.
Absolutely not.
No.
Should not.
So
You should
actually,
not give any post-operative.
Any indication of giving post-operative GnRH analog? Any indication when you are doing the surgery for endometriosis? I think there are few indications where you will like to give post-operative.
Can I?
There is a study by Salam et al. Which says that there is a 3 to 4-fold increase in the pregnancy rate if you give 3 to 6 months of GnRH agonist after doing surgery and then pose the patient for IVF. So immediately before IVF, if you give leupride, then the success rate is very high. But then that was in 2006. What I feel now is that the times have changed, and since now we are more into freeze all policy, the scenario has totally changed. So maybe
what do you do?
We can do antagonist cycle, do pickup, then maybe if required do surgery and give GnRH agonist, and then do frozen cycle.
Yeah, so that is one approach. I agree. You can do that in a selected group of patients. Kundan, you will like to add something here?
Yeah, actually, the indication for post-operative GnRH agonist only two scenario. One scenario where it is a grade 4 endometriosis and it is really beyond dissection.
Yes. So I think Kundan has brought out the point what I wanted to say. If you are not able to do the complete surgery and you are thinking that you have left a lot of tissue, I think these are the patients. To avoid recurrence, you can give a post-operative GnRH analog before proceeding. That is one indication, very selective, very selective. Any other indication?
I think if you have, if you are planning, most of the time these patients are put on for IVF, and if this patient is associated with severe adenomyosis, I think even those patients needs a suppression if you are planning for a fresh transfer. Now, in case if you are not planning for a fresh transfer, then in that case, frozen embryo transfer, then what Chaitanya suggested, that go ahead with a antagonist protocol and get the embryos, freeze them, and then do the frozen embryo transfer under down regulation of GnRH agonist. So that will be another.
Yeah, so I think, see, because still the practice is, has not moved to freeze all. There are a lot of restrictions when we talk of freeze all. It is very easy to say that I will be practicing freeze all policy. But when you come to the practical implication, there are a lot of practical implications. So you should be actually variable in your approach. You have to individualize all cases, whether you are going for freeze all in this case. If there is no harm, and at present, 80% of our cycles are still fresh cycles. Okay, so you can go for fresh cycles. There is no harm. As far as the agonist is concerned, we have been using agonist for so many years, so we should not discard it. I think there is a role of ultra long protocol in these patients. So you should not just discard it that I will be doing all antagonist cycle. I will not be using, because we know that there is implantation failure if you don't use agonist and you transfer. Okay. So either you freeze them and then use GnRH analog, you will get a better pregnancy rate, or alternatively you do the dissection, do the bulk reduction, and then give a ultra long protocol for 8 week or 12 week, whatever is your protocol. Both I am using 8 week, somebody may be using 3 months, so that is okay. And then if you do the pickup, you will be having a better fecundity.
Kuldeep sir, this just a practical concern on this point. If you give 3 months to 4 months of say GnRH agonist, will it not cause a lot of suppression of the ovary? And you require
so that's why I am using. I have done a very large study, 8 weeks versus 12 weeks. I don't find any difference in the fecundity, while we are having more suppression and we are using more gonadotropin in 12-week group. So that's why I have been using 8 week and then going ahead.
I think that is a very important point. People should come to know this, that long suppression of 12 weeks is not good. 8 weeks is better than 12 weeks.
Yes. So that is giving almost same result. because we are suppressing the ill effect of endometriosis on implantation, and then when we are transferring, I think so. If you are using antagonist, there is no harm. If you are using agonist, there is no harm, but you should know how much to give and when to give. Okay. So, of course, we have already discussed the coagulation versus excision. So, that is again we have covered. So, we move on to the next question. So, we have discussed post-operative hormonal treatment, only these 3 or 4 situations. Otherwise, just after surgery, you should move on to IUI or IVF, whatever you are deciding. Now, in this patient, again, your decision will be based on 2 things: how much correction you have done, what is the tube-ovarian relationship, and what is the disease grade. Even if you have done a very good dissection, if it is grade 4 endometriosis, suggestion and recommendation are that, because fecundity will be low in these patients, even if you have done a very good surgery. So, the preference is towards the IVF in high grade disease. If you are dealing with grade 1, grade 2, certainly these patients are for IUI for 3 cycles and then move on to the IVF. If you
Sir, what I believe in this, particularly after the post-operative treatment, sir, basically there is a scoring system. If your disease is too much of grade 3, grade 4, it is better to go for aggressive treatment for IVF. If it is just a milder of endometriosis, IUI or planned relationship will work. So these are the reverse American fertility scoring system. So you can take care of that.
Kuldeep sir, just one point. Here there is a role of endometriosis fertility index. Actually, EFI is something which is specially designed for non-IVF cycles, where they focus on the fimbria, the tubes and the ovaries, along with the other factors like history of duration of marriage, history of previous pregnancy, and age of the patient. So these are the factors which are considered. So this is, I think it's a very good scoring.
That is the scoring.
How many people in my panel are using scoring system?
In our MUHS fellowship, one of our students, we gave this topic for the presentation.
My question is, how many of us in panel are using scoring system?
The endometriosis fertility index is a good scoring system, but it is too cumbersome for our routine general practice.
That is the problem. That is the problem. We need to have, see, American fertility system scoring is for the very long. Why that was discarded? Because it is so cumbersome. Fertility index is a very good scoring as far as the score is concerned, efficacy is concerned. But the problem is, it is really a little more cumbersome. Whenever you are doing surgery, you are focusing here, and I think scoring, if you can do, very nice. If you are having a person like your resident there, you should use scoring, you will be better off. So my advice is, everybody should use scoring, but if you are not able to use scoring, the same thing you can just calculate just post-operatively what you are going to, based on that. So actual scoring will really help in deciding, but if you are not able to score, at least see what you have done. What was the position of fimbria? How many adhesions were there? Where was the ovary? So these things, they are going to decide your future treatment. So that is my advice. What I do in my practice, I may not be having many times a resident with me. So putting on paper, if you can do, it is certainly good, and it will give more information. So that is what is required. You should use fertility index if you are able to, because it is little cumbersome. So that is the clinical tip basically I am giving. Academically, yes. For research purpose, yes, it is very important to quantify your disease, and scoring system will quantify your disease and will help in counseling. Okay. So this is the patient. This is coming to Dr. Kalyan. Kalyan, are you there?
Yes, sir.
Yeah. So 18-year-old girl, severe dysmenorrhea, ultrasound shows 4.5 centimeter endometrioma in right ovary and 3.5 centimeter endometrioma on left hand side. How will you manage?
Usually, these are the young girls who have endometriosis with dysmenorrhea. These are the patients who are managed medically. Either I like to use OC pills for a longer time, 3 to 6 months, which is going to be good for her. But telling her that it is endometriosis is a disease of which is of progression, and she can have further complications for her reproductive career in the future is what counseling is required.
Yeah. So my all panelists want to add something. Amol.
So we have to also see, because it is bilateral endometriosis, whether there is any hydronephrosis, any features suggestive of back pressure on the kidney, because in such cases, then maybe we will have to look for, think about surgery. Second thing is associated, of course, medical management would be a preferred option in such patients. Because because we have to counsel them regarding the recurrence in future, and also if we do a
So you
cystectomy,
are in favor of surgery or medical? You are in
medical
favor of
management.
surgery or medical? Chaitanya?
Yeah, sir, she is 18-year-old. So I would avoid GnRH agonist in this patient because the bone development is not yet complete or maybe just
So
finished.
what
So
will you give? What will you give?
at young age, I would avoid GnRH agonist. Dynogest is a good option.
So you will be using Dynogest, not OCP?
Yeah, that is what OC pills and Dynogest.
Okay, so Dynogest or OCP. Kundan?
I think this scenario particularly goes for only Dynogest, because long term here, even if we give OC pills, now there was a study where it has been mentioned that long term complications or consequences associated with oral contraceptive pills is always a concern. And here the more safer drug will be Dynogest, because we have an advantage that we will completely create a amenorrhea with continuous administration of Dynogest. And also it has been shown that with Dynogest we have almost 40% resolution of disease at the end of 6 months. So, and we can give it for almost 2 years, where we can really achieve that this significant amount of decrease in these all kinds of cysts with endometrium.
We have studies of 5 years now, 5 years study.
Yes, I agree with you. So almost we can see a disappearance of the cyst at the end of 2 years if we continuously administered. So that by the time she's ready for her life reproduction, maybe at the age of 23, 24, 25, after marriage, we can actually reduce the disease burden significantly.
Yeah.
And one more advantage about Dynogest would be definitely the non-androgenic activity, because OC pills, if given for a long time, will have other side effects on lipid dysfunction, and mineral corticoid activity is not there with Dynogest. So
if you are using OCP, what OCP you will like to give? So you don't have these type of symptom?
Dynogest containing OC pills like 3 days can be used.
3 days 30.
3 days 30.
I will not touch that point, because otherwise it will eat whole panel into that discussion. See, OCP, the benefit of OCP is it is very cost effective. I think that should come first in the mind. When we are choosing
containing OC pills, I think.
Yeah, when we are so because the cost is one really constraint. When you are writing Dynogest for a longer period, many of your patients, they may not be able to afford the treatment, and they may discontinue. So you don't want that. Okay, so it is really important to go into the finances of the treatment, because it is a prolonged treatment, and patient should not discontinue because of the cost. So that is one thing. Of course, OCP, because we have been using OCP for years together before Dynogest came. Dynogest is having a lot of advantage, but all our panelists they have said. But efficacy wise, OCP and Dynogest are almost same. I will prefer Dynogest because of many reasons. I will tell you later. Ashish.
Yeah. Sir, in this particularly if the problem of this particular girl, she's 18 years and she's adolescent. So there is a definitely no to a general agonist that all of us are agreed upon. Secondly, coming to the OC pills and the Dynogest, if the cost is concerned, OC pill is having a better hand as far as the Dynogest is considered. But Dynogest is a drug of choice nowadays, and it can be given for a prolonged time. Secondly, sir, in this particular patient, if it is a bilateral endometrioma, I also worried about her future reproductive outcome as well as the recurrence of the disease. Even if we are going for any type of a medical line of a treatment, so there is something that you need to talk to the patient that there is a fertility cryopreservation techniques are available. So you can definitely talk and at least give them education about the cryopreservation or fertility preservation.
So can I put point one?
Sachin, you have not added anything.
Yes, sir. Sir, looking at the history, I would primarily probably counsel this patient for surgery. She is having severe endometriosis, bilateral endometriomas, probably a frozen pelvis looking at the history. So a laparoscopic excision and a good job at it. If she is not willing for it, then second line, what I normally start in a lot of these young girls is ormeloxifene. And it works wonders. I have given in patients up to 5 to 7 years. There is absolutely no side effects with ormeloxifene. Extremely safe drug, and the best part about it, it is then needed to be given only once a week. And so that is another thing that I've been using. And very cost effective, 10 rupees per tablet. And OC pills in such a young girl, I would not.
Sachin has opened another Pandora box. He is very good at it.
Yeah. Regarding ormeloxifene, I have also used it and very good results with ormeloxifene.
Sir, our Indian ormeloxifene is excellent.
No,
I have used it in endometriosis, adenomyosis, fibroid uterus, breast fibroadenomas, and it works wonders with zero side effects and most cost effective.
But I am discussing here surgery versus.
Sir, no to surgery, because I really feel so. If it is she's 18 years old and you are putting her for a surgery, whosoever it may be the surgeon, in her lifetime she has a higher chance of recurrence.
So what are the patients? What are the patients you will go for surgery straight away? My question is very direct now.
Yes, sir.
Only if there is hydronephrosis,
severe pain, and
if there is hydronephrosis.
One by one, there are four indications. Four of you can take.
Severe pain.
Yes.
If it is a symptomatic patient, bilateral hydronephrosis, then definitely there is a role of surgery. Otherwise,
severe pain is not an absolute indication. Let me tell you.
Pain not
endometrioma rupture.
Pain
not responding to your medical treatment. That is one indication.
Yes.
That is one indication. So
endometrioma rupture.
Endometrioma rupture. Second, third.
Hydronephrosis in both the kidneys. Or
yeah, so pressure symptoms which are endangering the kidneys, and fourth,
bladder.
last one.
And lastly, if rarely there is a torsion.
Torsion, no.
Quite rare.
Will not, right.
Rectal endometriosis.
When there is a doubt, in the diagnosis and it is malignancy.
If it is a malignancy, there is a doubt of a malignancy.
Even if you are having a doubt, you should go in. Otherwise, apart from these four indications, primary treatment,
symptomatic rectal endometriosis is another indication for
that we have, because she is not basically responding to your medical treatment. But in all these patients, medical treatment is first line drug. In adolescent endometriosis, first line therapy, and before putting a laparoscope, you should think 100 times. I am because this is again very clear that surgery is one thing which can give you a very high success rate as well as very high morbidity and mortality. Okay, complication rates and everything. You have this patient, 18-year-old, she is having whole life. If you have not done a complete surgery here, she will undergo for multiple surgeries, or she will have to go for egg donation program. So please don't put laparoscope unnecessarily in younger patients. In younger patients, they are very defined indication. You can go ahead for surgery in these four indications. One more thing of Dynogest or OCP. whether it should be given cyclically or continuously.
Then it is continuously.
Anyone cyclical?
No, sir. Always continuously. Then only it is very effective.
So again, it is very important that whenever you are starting medication in these patients, it should be given continuously at least for 6 months. If you are having a breakthrough bleeding, because that is one side effect of medical therapy, that patient may have a breakthrough bleeding, don't worry, leave the medication, let her bleed, and then continue the treatment. At least because if you keep on giving it cyclically, patient will have very high recurrence rate. Once you stop the treatment, there will be recurrence again. So continuous treatment, at least for 1 year, 2 year, whatever is the patient is there. What about GnRH agonist? You have given OCP, you have given Dynogest, patient has not basically having symptom free. She is not symptom free. She is still having pain. GnRH agonist, she has become now from 18 to 19. Agonist, anyone?
Not at this
Sorry,
stage.
the question is that when she goes
So
to
what will be the age when you will consider GnRH agonist?
After 21 maybe. Not at this stage.
Anyone? Kundan, Ashish?
If we compare Dynogest versus GnRH agonist, then the results are almost similar, and the side effect profile of Dynogest is better than GnRH agonist. For
no, but she is not responding. She is not responding.
If she is not responding to the Dynogest, or for that matter, OC pills, she is unlikely to respond to the GnRH agonist. And in this particular situation, we are not like to give her a GnRH agonist.
Okay, I think there are few papers fail the oral treatment. GnRH agonist can be given with caution. Okay, with caution. Of course, you have to give advac therapy whenever you are giving GnRH analog. So that is one. See, this patient is having only two options now. Either goes for GnRH agonist or for surgery. So that you have to decide what will be the best for her. You can do surgery in this patient because she is not responding. You can go for GnRH because she is 19, borderline. So, but not before 18. Okay, not before 18. 19 is the age where you can counsel the patient. You can see the pros and cons of both the treatment, and then you can decide. So this we have covered very nicely. How much time, Rohan, we are having? We can take one more case.
Huh? It's already 8:20 actually.
Yeah, so we can take one more case. I am skipping this. We have already discussed recurrence. What do you do in recurrence? This patient has come with recurrent endometrioma, P2L2, 34 years, recurrent endometrioma. Patient has already gone for 2 surgeries.
More conservative approach should be followed.
Like,
first approach will be either medical management, or second alternative we can give is a progesterone IUCD to this kind of patients.
Okay, so I think that is what I wanted to bring. These patients, they respond very nicely with the LNG IUD. So recurrence, younger patient, not wanting definitive surgery, you can certainly try medical management in these patients. Either you can go for Dynogest in these patients, or start with GnRH agonist and then move on to the, because GnRH agonist, because these are the patients where if you combine agonist initially and then maintain them on Dynogest, they fare very well. So that is one suggestion, that you give agonist in the recurrent endometriosis and then maintain them on Dynogest, or you can put them on LNG IUD.
Has anybody tried LNG IUCD in unmarried girls or young girls?
Usually LNG IUCD, they are not, there is not much suggestion that they should be tried. Anyone for letrozole?
About my experience of LNG IUD, I am
Yeah.
using it. Previously, I used to do thermal balloon ablation for these mentally retarded girls, and now I am using LNG IUS for these mentally retarded girls.
Okay.
That is it.
Okay. Okay. So anyone have used letrozole in these cases?
So the problem with letrozole is that for a short term you can use it for a symptomatic relief, but for a long term it causes a severe hypoestrogenic changes. So that is why letrozole goes for a second option.
So
Yeah,
letrozole I am using for those patients with deep infiltrating endometriosis with hysterectomy done. With you feel that there are so many implants remaining in the pelvis, then I am using letrozole. Otherwise, no experience of.
Let me tell you my experience with letrozole. Letrozole is very, very good as far as the symptomatic relief is concerned. Whenever OCP Dynogest is failing, you can try letrozole. Only problem is prolonged use is not recommended. There are not many studies. Actually, recommendation has not come because there are not many studies. People have not tried for
In
more
breast
than.
cancer, it is used for a longer time, sir.
Yeah. So, but in these endometriomas, 6 months I have used, but I was not very sure that I should be using more than 6 months. But whatever patient I have put on letrozole, they are very, very, very happy. Very happy. It is cost effective also. So
Yeah,
letrozole is one.
aromatase inhibitor. Yeah.
Yes, aromatase inhibitor can be given.
Can use a dydrogesterone also, sir. Or if
Dydrogesterone, there's not much. Any progestin you can use actually, but the cost effectiveness and efficacy both comes into the way of dydrogesterone. So that is not a very good choice. We are having Dynogest there, which is actually very effective, very compliant, very friendly. And I think that can only problem is cost. So that if you can manage that, I think that is good. So last case I'm looking here. Okay, this one, 27-year-old girl with adenomyoma, 14-week size, uterus, severe dysmenorrhea and infertility. How will you proceed? Anyone can take. Yes, Chaitanya.
Yeah, actually, as far as the laparoscopic surgery is concerned, it is not very easy to do resection of adenomyoma. So only the experts, in fact, should do adenomyoma.
What will you do? I consider you.
It can be done open also.
No. Being done open or laparoscopy, it is has to be a localized adenomyoma. Then only you can operate. Otherwise, a generalized adenomyoma you cannot operate.
I agree with
For
Kalyan.
such patients, we need to put
one by
LNG.
one by one, please. One by one.
For such patients, I like to put an LNG IUS for some time, maybe 6 months or 1 year, and then we'll decide if the size
will not work. It will get extended.
I have experience of
Kalyan, she is infertile. She has come to you for infertility.
Kuldeep
sir,
sir,
size is 14 weeks, sir. Size is 14 weeks.
Yeah,
Kuldeep
so
sir, I'll just share my experience.
Yeah.
I have 4 such patients where the patient had severe pain, and what I did, I put LNG IUS along with GnRH agonist, because LNG IUS takes 3 months time for its action to start many times. So what I did is I started with LNG, put LNG and started with GnRH agonist at the same time. 3 months of GnRH agonists were given. By that time, LNG IUS started working, and the patient was completely relieved of pain. So I have tried this in 3 to 4 patients, and it has given excellent results.
Patient want pregnancy.
Sir, I like to add at 14 weeks of uterine size, she's just 27 years of age. I have 6 months or 1 year time to reduce the size of the uterus, reduce the symptoms, and then only. So she wants a baby, but that doesn't mean that I'm going to give her within 2 months, because she's 14 week size. That is why LNG IUS has some role. That is my
LNG is one thing. How many people in the panel will agree with Kalyan?
Sir, first of all, I like to know whether it is a localized or generalized adenomyosis. If it is focal adenomyosis, it is definitely, there is a role of laparoscopy adenomyomectomy at 14 weeks.
First line,
If it is generalized, then definitely LNG IUCDs will be.
Ashish, first line surgery you will recommend in this patient?
No, sir.
As a first
If
line,
it's a localized adenomyoma.
it is localized adenomyoma. Are you going to go in for resection and then start the treatment?
Yes, I'd like to.
Anyone who agree with Ashish or disagree?
Sir, can I comment?
Yes, yes.
Sir, it's not that every diffuse severe adenomyosis will have a very significantly reduction in the implantation rate. So I think I will give value more for evaluation of endometrial thickness and the blood flow. Now, if I find it that these two parameters are compromised, I will like to go ahead for a short-term down regulation and do a kind of a frozen embryo transfer or something like that in this case. But if it is kind of a focal adenomyosis, the endometrial thickness is good, blood flow is good, we don't need any intervention for this kind of adenomyosis because the pregnancy rates are not reduced.
So basically you are saying, you will go ahead with GNRH analog and then do IVF and then transfer. Is that so?
The embryo freezing has to be prior, and then when you do a frozen embryo transfer, then give a suppression for a little longer time. Now there is a very good meta-analysis where it
that makes sense. That makes sense, Kundan. I do agree on that. Anyone who will be doing surgery at first place, and Ashish is there one. Chaitanya, what you will be doing?
No surgery, no surgery.
Sachin?
Surgery.
Sachin is surgeon, so he will do surgery. Kalyan?
And no surgery at the first place, sir.
Okay.
So I completely agree with Kundan. You have to freeze all, followed by long-term GnRH agonist, followed by transfer.
Transfers. Yeah.
Yeah. So I think that is the recommendation. Surgery is having a role, but not primary first line. So it is always, and that has been the practice till now. Of course, there are a lot of studies which have. See, problem is even if you do surgery, the fecundity rate are not very good. That is number one. Second, all these patients, they are having very high chances of miscarriage. Okay. Now there is a lot of literature which has compared medical first and then going on to the surgery, combining medical with surgery and alone, the three arms, one surgery, one combined medical and surgery, and one medical management. What we found, and that has been now my practice also, primarily first cycle is always medical until unless it is very huge and you can't proceed. Okay, so size will certainly matter when you are deciding for surgery. Okay, but up to 12 week, I think straightway you can think of medical management. Problem comes after 14 week. After 14 week, because 14 to 20, I have done up to 24 week. So I am having that these patients, like this patient was 24 week, around 24 week. It was a huge endometrioma here. And because see, adenomyoma is not very easy to perform. That is number one. You have to do the bulk reduction. You don't know how much to reduce. So mapping has to be done before you start. You should be knowing how much will be, otherwise you will be opening the cavity. So at least 1 centimeter should be left from the endometrium whenever you are doing the adenomyomectomy. And of course, the results are improved, but usually patients end up into the, I am having a series of 30 adenomyomectomy or debulking. Results improved when you compare to medical therapy alone. But miscarriage rate were again up to 40% of these patients, they do end up in miscarriage. So that is the black point in the management of adenomyosis. But many patients will take home babies after combination of GnRH analog, adenomyomectomy, and frozen embryo transfer. So what is recommended ideal in these patients? You take out eggs, do the frozen transfer, first cycle medical. If it fails, you can offer surgical combined with medical, because you are having frozen embryo, so you can use them for multiple cycles. So that is the ideal management in these patients. To sum up, I will require one comment from all panelists about the adenomyomectomy. Whenever you are doing adenomyomectomy or debulking, what are the problems? What do you prefer? What is the approach? Like anyone can give one point.
Wedge resection is important step. Wedge resection first.
Okay.
Secondly, with the barb suture, life is quite easy nowadays than we used to use Vicryl previously.
Okay, again, suturing, when it comes to suturing, if you compare the myomectomy suturing, post-myomectomy suturing and post-adenomyomectomy suturing, there is a lot of difference when you are suturing the adenom, because there is a lot of hyperplasia, a lot of fibrosis when you are suturing. So there is a lot of problem in suturing also. So you have to be very good when you are doing a adenomyomectomy or debulking. Myoma you can do, myomectomy is easier to do, but when you are doing adenomyomectomy, I think expertise comes into play. Ashish.
Yes, sir. First, when you are talking about the adenomyoma, you need to do a mapping.
Yes.
You need to know how much you wanted to resect. Whether you are like a endometrium, you need to know whether you are how much close you wanted to go. Secondly, there is a technique like a wedge resection as well as a double bracing. So if the defect is too much, so you can do it in a double bracing manner of a suturing. And if it is just a wedge resection, you can suture in one layer.
Kundan?
Think surgery as a probably a second option than the first option.
Yes, agree.
When it comes to
Chaitanya.
infertility.
Chaitanya.
Adenomyosis surgery is always tricky, and it is not that easy. Sometimes you end up doing nothing. You remove a small piece of adenomyoma, and then you feel that you have done nothing for this patient, and it is of no use at all. So though we have also tried adenomyomectomies in many patients, but I always feel that it's frustrating surgery if you compare it with myomectomy, which definitely gives a very good feeling. Adenomyomectomy is not that good surgery.
Kalyan.
So again, wedge, I told about the wedge resection and suturing part, sir.
Yes.
It is not to be done always. Okay. You have to decide which patient to be taken. I will like to do if it is only localized adenomyoma, otherwise I will not go for surgeries.
Amol, Dr. Amol.
Yes, so absolutely. In localized adenomyosis, surgery can be done, especially if it is distorting the cavity. And as Dr. Ashish rightly said, that during surgery, we have to be very much sure, because the anatomy is many times distorted. The cavity should not be opened, or we should be very much clear about the endometrial cavity. We can also use a transvaginal sonography guidance during the surgery while we are resecting the adenomyoma. And if the wedge resection is usually done, but if the defect is usually to be closed in at least 2 layers, and as Dr. Ashish rightly said, that if the defect is large, then we can use a double flap method to close the defect.
Okay, nobody has commented laparoscopy versus abdominal. Is there any comment on that?
Sir, can I?
It will give similar results, sir.
Yeah.
Sir, laparoscopy versus open, it depends upon the skill of the surgeon.
Okay.
I preferably do
laparoscopy. That is what I wanted to hear. So it is not necessary that you have to go for laparoscopically, but certainly laparoscopically the recovery and the benefit of laparoscopy. So that will be there. But if you are not very comfortable, you can go for open. There is no problem there. So that should not be deciding factor whether you have to. So you have to be comfortable. See, problem is you have to give your best whether you are doing open or laparoscopically.
Kuldeep sir,
yes.
just a point.
Yeah.
At open surgery, what we normally would advise is after the surgery is done, suturing is done, to give a thorough wash the way we give after laparoscopy. That greatly reduces the pain and the adhesion formation after an open surgery. A good judicious lavage with 1 to 2 liters of saline.
And of course, the use of interseed.
Interseed, yes.
Okay, so I think my panelists, they were very brilliant. They have done really wonderful job. They deserve a very good round of applause. We may not be able to hear, but certainly we can show that it was really a wonderful panel. We have almost done 1 hour, 30 minutes discussion. So question, there are 2-3 questions. Are you ready to take?
Yes, yes, definitely.
I think we have already discussed all these.
Everything is discussed.
Yeah, so we have discussed. So I am again thankful to everyone, all panelists, and Rohan, I can't see you, so can you come on?
Rohan has gone for a C-section.
Okay,
He's just put in the group.
Okay, but I think his effort was really wonderful, and I thank all the audience, and I hope that we have given few very important messages through this panel discussion, and they will be really useful to everyone. I will like to thank Dr. Nandita, AMOGS President, Dr. Sunita Tanvulkar, Dr. Amit Patki, Dr. Arun, and the whole team of Rohan, who have really done a wonderful job. I will like to thank Dr. Deepika from Jagsonpal and her team. They are very, very supportive in all our academic. When I was endometriosis chairperson for last 3 years, they really supported all academic events without any condition. So thank you, Dr. Deepika. And we have done actually a very wonderful survey of adolescent endometriosis. That is a very, very decent or very unique piece of paper, which is actually first time we surveyed 2,500 plus adolescent girls, went to the school room, and so we were able to find out the prevalence of adolescent endometriosis, how it is taken, how dysmenorrhea is taken into our society. And we found that adolescent endometriosis is more common in South. So we divided actually in zones, and it was more common in South. But medicine for dysmenorrhea are taken more in North. So that was something. In South, they don't, the medical facilities, though they are available, but prescription rate were not very high. So these were some of the very good findings. So thank you again, everyone. I hope everybody will take care in Corona. So thank you very much.
So on behalf of Jagsonpal, makers of Endoreg 2 mg tablet and injection Gonadoreg 3.75, I am Dr. Deepika Chabra, and along with my teammates Dr. Vipin Tyagi and Mr. Amit Saxena, we appreciate and thank all the experts for taking out valued time and sharing vast knowledge with us today. We at Jagsonpal would like to reassure all the experts our extended support to your future activities in the service of women's health. We appreciate the presence of all the attendees. Without your support, this initiative could not have been possible. So we go a long way.
Before I leave, I request again all of you to support me for my vice presidentship in Proxy this election. So thank you very much, everyone. Thank you.